Good morning, everyone. At the outset, I would like to thank the organizers of the Indian Society of Medical and Pediatric Oncology for having given me this opportunity to talk on the treatment of pancreatic cancer, looking below the tip of the iceberg. Almost 500,000 new cases of pancreatic cancer were diagnosed in 2018 worldwide, and the prevalence of pancreatic cancer is higher in the developed as compared to the lesser developed countries. The pancreatic cancer prognosis is quite dismal, and we are seeing here that even in localized pancreatic cancer, around 34.3% of the patients only survive at the end of 5 years. And when it gets worse, as we talk about regional, distant, and very advanced diseases. And talking about the staging of the pancreatic cancer, which determines the resectability, based on the vascular invasion, it is classified into resectable, borderline resectable, and unresectable based on the vascular invasion. Now let's talk about the resectable disease, neoadjuvant and adjuvant therapy strategies. So what is the rationale behind neoadjuvant chemotherapy? What are the advantages and disadvantages? Talking about the advantages, uh, uh, greater ability to administer systemic therapy without delay or concern regarding post-operative complications. It can assess drug sensitivity of tumor in vivo and also select patients most likely to benefit from surgical intervention. What are the disadvantages? We could lose the window of opportunity for curative operations and requires preoperative biopsy or biliary decompression, especially when patients present with obstructive jaundice and which requires a stent management and further chemotherapy once the bilirubin normalizes. So let's start with the neoadjuvant approaches. So the PREOPANC 1, which looked at the neoadjuvant chemoradiation versus immediate surgery for resectable pancreatic cancer. So it was an international randomized controlled phase 3 trial, which included adult patients with good performance status and resectable or borderline resectable pancreatic cancer, close to 250 patients who were randomized to gemcitabine followed by gemcitabine with radiation, followed by gemcitabine alone, followed by surgery, and followed by adjuvant chemotherapy, as compared to surgery followed by gemcitabine for 6 months. The primary endpoint was overall survival, and the secondary endpoint included R0 resection rates, disease-free survival, distant metastasis-free survival, and loco-regional relapse-free survival. So looking at the overall survival, there was not much of difference between the two arms, and it was not statistically significant. But the R0 resection rate was more in the preoperative chemoradiation arm as compared to the immediate surgery arm. And similarly, the median loco-regional failure-free survival was not reached in the preoperative radiochemotherapy arm as compared to the surgery arm. Looking at the preoperative modified FOLFIRINOX versus gemcitabine plus nab-paclitaxel for resectable pancreatic cancer, the SWOG S1505 trial. So this was a phase 2 randomized open label trial. Patients with resectable pancreatic adenocarcinoma with no previous cancer therapy with a good Zubrod score and close to 150 patients were randomized to modified FOLFIRINOX once in 2 weeks for 12 weeks. And as compared to gemcitabine nab-paclitaxel, the usual 1-8-15 of a 4-weekly cycle for 12 weeks, and the patients were restaged. And subsequently, if there was no progressive disease, underwent surgery and subsequent adjuvant treatment. And what was interesting about the trial design was the winner was picked at the end of 2 years, but there was a basic requirement that at least the OS in either of the arms should have at least at the end of 2 years should have been more than or equal to 58%. But unfortunately, the study did not meet its primary endpoint, and the 2-year OS in both the arms was less than 58%. It was 43.1% in the modified FOLFIRINOX arm as compared to 46.9% in the gem nab paclitaxel arm. And what we can see here is that R0 resection was equivalent in both the arms, but the complete and major pathological response was slightly more in the gem nab pacli arm. And similarly, there was a numerical advantage in the DFS after resection in the gem nab pacli as compared to the FOLFIRINOX arm. But however, it is difficult to draw a conclusion one way or the other, and we could say that both of them are similarly efficacious. Coming to the Alliance A021 A21501 trial, which looked at the neoadjuvant modified FOLFIRINOX with or without radiation in borderline resectable pancreatic cancer. So adult patients with the borderline resectable pancreatic adenocarcinoma with good performance status, phase 2 trial, were randomized to modified FOLFIRINOX 4 cycles in both the arms, subsequently plus or minus radiation, and then restaged for surgery and subsequent adjuvant treatment with FOLFOX. The primary endpoint was an 18-month overall survival rate, and the secondary endpoint was event-free survival, safety, R0 resection rate, and pathological complete response rates. And what was seen here is that the modified FOLFIRINOX led to an improvement in the 18-month OS rate as compared to the radiation plus FOLFIRINOX arm. And similarly, the median EFS, event-free survival, was also better in the chemotherapy arm as compared to the chemoradiation arm. Coming to the adjuvant trials. So we do know that gemcitabine was initially the standard of care. This trial, the SPAC4, looked at the adjuvant combination of gemcitabine plus or minus capecitabine in resected pancreatic cancer. It was a multi-center, randomized, open-label phase 3 trial, close to 750 patients. And what you can see here is that the median OS was better in the gemcitabine plus capecitabine arm as compared to the gemcitabine arm. The hazard ratio of 0.82 and the p-value was significant. Coming to the PRODIGE trial, which looked at the adjuvant modified FOLFIRINOX as compared to gemcitabine in resected pancreatic cancer. Again, a phase 3 randomized trial, patients with R0 or R1 resected pancreatic adenocarcinoma with a CA 19.9 of less than 180 units per ml at 12 weeks post-surgery, good performance status, no prior chemotherapy or radiation. Close to 500 patients were randomized to modified FOLFIRINOX of 12 cycles versus gemcitabine, and subsequently CT scans was done every 3 months, and the primary endpoint was disease-free survival, and the secondary endpoint was toxicity, overall survival, cancer-specific survival, and metastasis-free survival. And what was noticed here is that there was almost a doubling of the DFS in the modified FOLFIRINOX arm as compared to gemcitabine, and very impressive hazard ratio of 0.58. Similarly, the median OS 54.4 months in a pancreatic malignancy is quite heartening to see as compared to 35 months in the gemcitabine arm, and the hazard ratio of 0.64. But of course, it came at an added toxicity of 75.9% in the modified FOLFIRINOX arm as compared to 52.9% in the gemcitabine arm. Coming to the adjuvant nab-paclitaxel plus gemcitabine versus gemcitabine alone in resected pancreatic cancer, the APAC trial, which was a phase 3 randomized open label trial, treatment naive patients with surgically resected pancreatic cancer, good performance status. And the patients were randomized to the combination of gemcitabine plus nab-paclitaxel versus gemcitabine alone. And what you can see here is the primary endpoint was disease-free survival, and the secondary endpoint was overall survival and safety. And the APAC trial showed that the DFS was equivalent in both the arms. And though there was a trend towards statistical significance of improvement in the OS in the combination arm, but the hazard ratio was 0.82 and the p-value was just less than 0.5. It was 0.045. But again, difficult to draw conclusions, maybe a personalized approach, physician discretion, whether we could use this in the adjuvant setting. Coming to the metastatic disease, systemic therapy. So these are the different milestones which led to the approval of gemcitabine, FOLFIRINOX, and the gem-nab-paclitaxel. So the million-dollar question, which regimen is better, whether it's the FOLFIRINOX or the combination of gemcitabine plus nab-paclitaxel? We don't have a direct prospective study designed to trial to actually compare these two, but the PRODIGE trial looked at FOLFIRINOX plus as compared to gemcitabine, and the IMPACT trial, which looked at the combination of gemcitabine plus nab-paclitaxel in comparison with gemcitabine. And here you can see that the cross-trial design study comparison, FOLFIRINOX versus gemcitabine, the overall survival was 11.1 months versus 6.8 months. And in the gem-nab-pacli, it was 8.5 months versus 6.7 months. So was the PFS advantage in the combinations. And what you can see here, again, a cross-trial comparison, patients with the ECOG performance status 0 were more in the FOLFIRINOX arm, saying that probably they were more fitter. And the overall response rates, yes, in the FOLFIRINOX study, FOLFIRINOX showed 32%, but the gem-nab-pacli versus gem, it was 23%, but again, cross-trial comparison. And you can see here that the PRODIGE trial, which looked at FOLFIRINOX, did show that the fatigue, diarrhea, vomiting, and febrile neutropenia were numerically higher as compared to gemcitabine alone. There has also been retrospective data from the US oncology group, which has shown that gem-nab-pacli and FOLFIRINOX have shown similar outcomes. And this has also shown that, of course, like previously mentioned, the toxicity of more mucositis, asthenia, nausea was seen in the FOLFIRINOX arm. And the good thing to say here is that these rates of second administration, subsequent chemotherapy is more or less similar. So long story short, I think between FOLFIRINOX and Gem-Nab-Paclitaxel, it's difficult to decide which is better. Yes, modified FOLFIRINOX is doable in young fit patients, but and especially patients who are BRCA1 or 2 positive or PALB2 pathogenic variant positive, where you want to give a platinum-based chemotherapy, then FOLFIRINOX or GemCis would be an ideal regimen. But again, it comes with a little bit of added toxicity. This is to look at the maintenance approach, the PanOptimox trial, which looked at patients with pancreatic cancer who received initial FOLFIRINOX. They were randomized to FOLFIRINOX 12 cycles or FOLFIRINOX 8 cycles, followed by 5-FU leucovorin maintenance and reintroduction of FOLFIRINOX in case of disease progression. And in arm C, it included sequential therapy with FOLFIRI and gemcitabine. And what you can see is here that the response rate, the PFS and OS were similar in the FOLFIRINOX 12 cycles and FOLFIRINOX 8 cycles, followed by 5-FU leucovorin maintenance. So maintenance does work. This again to say the same thing, that initial FOLFIRINOX can be followed by 5-FU leucovorin maintenance or FOLFIRI maintenance. And if the patient has been exposed to gemcitabine plus nab-paclitaxel, then probably you can switch to gemcitabine monotherapy or modify the regimen. Instead of 1-8-15, maybe make it once in 2 weeks, or a regimen of gemcitabine and nab-paclitaxel instead of stopping the chemotherapy totally. So what about the second line approaches? So this was the Napoli 1 study, which looked at patients with metastatic pancreatic cancer who received prior gemcitabine based treatment. Close to 420 patients were randomized to receive the nanoparticle liposomal irinotecan plus or minus 5-FU leucovorin. And what you can see here is that the OS as well as the progression-free survival were actually better in the liposomal irinotecan plus the 5-FU arm. And this got FDA approval for use after progression on a gemcitabine combination therapy. So what about patients with actionable mutations? So NGS efforts have shown that close to 25% of patients have potentially actionable molecular mutations, including 5% of them who could have BRCA1 or 2 and PALB2, and 1% of them who can have MSI high and NTRK1 fusion protein positivity, and the other genes which could be positive in these patients. And around 17 to 25% of pancreatic adenocarcinoma patients harbor mutations in the DNA damage response genes. And this includes the BRCA1, 2, ATM gene, PALB2, and several others as mentioned here. And we do know from our ovarian and breast cancer malignancy that DDR deficiencies predict overall survival improvement in platinum treated pancreatic adenocarcinoma, as you can see here. And it is important to use this platinum in patients who are BRCA1 or 2 positive, or even a PALB2 positive pathogenic variant positivity. They may respond better to platinum agents. So germline testing is definitely recommended for all patients with confirmed pancreatic cancer using comprehensive gene panels for hereditary cancer syndromes. And similarly, somatic gene profiling is recommended for patients with locally advanced metastatic pancreatic cancer who are candidates for anti-cancer therapy to identify uncommon but actionable mutations. So the POLO-1 trial specifically looked at the phase 3 trial. It was a phase 3 trial of olaparib maintenance in patients with germline BRCA mutated pancreatic cancer. So metastatic pancreatic cancer, germline BRCA mutated patients, good performance status, and first-line chemotherapy included platinum compound of at least 16 weeks with no signs of disease progression and no toxicity of more than grade 2, excluding alopecia or neuropathy. And patients were randomized to 3:2 to receive olaparib maintenance versus placebo. And you can see that the primary endpoint was the progression-free survival, and secondary endpoint was OS and PFS2. So you can see here that the PFS was significantly improved, very impressive hazard ratios in patients who received the olaparib as compared to placebo. The overall survival, unfortunately, did not show difference in the final OS analysis, and it was not statistically significant between the two arms. And it did show, the POLO trial did show that the time to first subsequent cancer therapy as well as the time to second progression-free survival was also better in the olaparib arm as compared to placebo. So similar results were also shown with the rucaparib maintenance, You can see showed an impressive OS as well as PFS, and it also included patients with somatic BRCA. So this expanded the coverage as compared to olaparib. So there are additional targeted therapies also for MSI high. There is the Keynote 058 trial, which is showing an overall response rate of 18.2% with pembrolizumab. And if the patient is MSI high or TMB with progressive disease and no other standard of care which is eligible, then subsequently patients can be exposed to pembrolizumab. Similarly, the larotrectinib and enotrectinib can be used for NTRK fusion mutations positivity. To summarize, neoadjuvant modified FOLFIRINOX seems to be a reasonable option. The results of the PRIOPANG 2 would address whether neoadjuvant CTRT is better than total neoadjuvant FOLFIRINOX. Modified FOLFIRINOX may be considered in young fit patients as an adjuvant regimen, albeit with added toxicity, and gem-nab-paclitaxel in others. In patients with BRCA, PALB2, or other HRR gene mutations, platinum-based regimens should be incorporated in the metastatic setting upfront. And the role of PARP inhibitors as maintenance in patients with germline BRCA mutated positivity has significantly evolved and should be considered. Thank you so much for a patient listening.